So he gave me a talk that there is no way we can encompass in 15 minutes, so we'll share some highlights. They're completely, they're viewed together in terms of cardio-metabolic syndrome, but there's the role of ventilation, nutrition, and the multi-organ dysfunction. I think we have a lot of talks coming up later on in the afternoon and tomorrow about perfusion, hemodynamic derangements, and multi-organ dysfunction. I'll cover a little bit of sepsis in there. So one of the things in the ICU is you go through this, you walk in, multiple devices, you barely are able to figure out, okay, this person, what is the mean arterial pressure, what are the vent parameters, what are the LVAD devices at? And as you go through one by one and you want to understand what is the role of mechanical ventilation, I tried to look at what do we really know about mechanical ventilation as it pertains to cardiogenic shock. And when you look at the trials, the trial data in the last 25 years has given us some kind of highlight as it's as prevalent as 9% or maybe 88%. So it's all over the place. One of the greatest limitations in the last decade is if you look at mechanical ventilation as the only mode to really deliver oxygen delivery, then it can be looked at as a negative impact, right? But you all know in the last 5 years, we've really gone towards high flow oxygen, ability to really give high flow oxygen to wash out the carbon dioxide, to give humidified air, and to open up the upper airways to be able to give a PEEP of 7.5 up to without actually having a mask on or to give invasive ventilation. Now that's a paradigm change that happened in pulmonary medicine. The question is, how do we use that data to understand cardiogenic shock? And we really don't have that yet. We learned about PV loops in the morning, and you're going to keep hearing about it. But let's understand PV loops from the lung standpoint. I don't show a PV loop here. This is even more basic scalar. This is a pressure time scalar. When you look at the patient on the ventilator, your outcome measure that you deserve is what? A PF ratio that's acceptable to you, right? But to what cost? The alveoli, the type 2 cells, are some of the most exposed to environment after your skin. So the more pressure you give, the worse the outcomes are going to be in the long run. So you can't just look at the PV loops, just look at the PF ratio. You have to see what is the driving pressure that you need to arrive at that PF ratio. So the driving pressure that you'll see on the ventilator is the mean airway pressure, but that's basically all it is area under the curve. So you want to get to the lowest mean airway pressure to have your target PF ratio. Now, there's a lot of data coming out that you don't want 100%. The lower, the better. Now, what does that mean in terms of cardiac physiology with the ventilator? In the spontaneously breathing patient, you can see that the right side and the left side are dependent upon the venous return and the ability for you to take in the air from the respiratory system standpoint. But what happens to this patient when you are passively, you're taking in a deep breath, so you want to get more blood into the right ventricle, right? And then it goes into the lungs. But what happens if you suddenly add positive pressure breath to that? Suddenly, the right ventricle is like, wait, you're giving me an increased pressure. So that's RV afterload. And if your RV is already struggling, such positive pressure is going to be detrimental to the patient. But wait, your patient has LV failure, let's say. The positive pressure is going to be able to adequately oxygenate, push the capillary bed, and actually give you more preload to the left side. So even though these diagrams can be incredibly complicated, the more you look at them, make it simple. Positive pressure is really a good thing for the LV. The RV ain't gonna forgive it if the RV is marginal. That's an important concept to understand. So if your patient is already struggling on the right side, ask yourself, is intubation really needed? Am I going to make the situation worse? Now, if it is an isolated LV failure, we know you give positive pressure and these patients do well. What do we know in terms of published cases? Just look at the second column and look at the number of patients that have been enrolled. You can see the most you had was 21, 28, 10, 20. So there's really not that much data on what do we understand positive pressure does in terms of cardiogenic shock. Yet we routinely do it, right? Patient is sick because he's on a ventilator. But what does that really mean? One of the trials that was interesting to me, and I think this may be worthwhile for the structural cardiologists in the room, is they took a group of patients and they kept going up on the PEEP and to actually see what happens to the MR. The coaptation improved. I mean, these are great physiological examples, but we really need a lot more data to understand what happens with positive pressure. One of the papers that just came out in February answers this in a systematic way. How do you manage patients with mechanical ventilation? IM is invasive mechanical ventilation in cardiogenic shock. So you evaluate the patient, you make sure that they meet the criteria, but one of the things that I really liked in these algorithms are very strict initial ventilator settings. It gives you guidance. Use AC and PC. Don't use SIMV because that's going to go, you have no idea what it is going to do for the myocardial oxygen uptake. Number two, we talked about it. If it is LV, go up on the PEEP. You have a problem with the RV, be cautious with the PEEP. And then you keep going up on the PEEP, but make sure at the same time that your plateau pressures are not getting affected. Then the next thing is adjusting the PEEP in cardiogenic shock according to the ventricular function and loading conditions. I feel like out of all the papers out there, this is one of the first papers that has taken, even though the limited clinical trial data we have, and actually give guidance on this. The main thing to take away is make sure if you have right ventricular dysfunction and your pulmonary vascular resistance is an issue, increasing PEEP is not going to help you necessarily. So the RV afterload is going to be helped by pulmonary vasodilators, right? So these are the patients you may want to use your inhaled vasodilators on early on. Instead of intubating these patients, increasing RV afterload because of the positive pressure and further worsening your hemodynamics. Now, what if your patient has veno-arterial ECMO? We know tomorrow there is a debate about whether or not you unload these patients, LV vent. We know that there is the Harlequin syndrome that happens in these patients, right? So if your LVEDP goes up, then gradually there is worsening of oxygenation because of pulmonary edema. Now, one of the things that you can look at is a pressure volume loop on the ventilator. If you guys have the vents that can afford that, you will see early on as the LVEDP is going up and as the pulmonary edema, your pressure volume loop on the ventilator is also going to the right. It's taking you higher pressures to get you desired volumes. Then, do you have any algorithms to liberate the patients from mechanical ventilator if they have cardiogenic shock? One of the most frequently misunderstood things, and I think the critical care physicians in the room will agree upon, is the cardiologists and the surgeons coming. This patient is ready to get extubated. How many hands up in the room? Where the critical care physician is like, it's not the lungs, it's the heart. The minute that I extubate, your mixed venous is going to drop 10 points, and you're going to claim that it's the lungs. It was never the lungs, it was the heart. So keep them intubated. Give them the support that they need. Now, getting to shifting gears, nutrition in the ICU. I have some of my dietary colleagues in the room. What are some major goals that we want to accomplish in the ICU? Acute critical care illness, we know, is a catabolic state. As the body recovers, it shifts from the catabolic state to anabolic state. Unfortunately, at the bedside, you don't have measures that are suddenly telling you, hey guys, I'm in an anabolic state right now. This is the time for me to get extra nutrition or to alter nutrition, right? So we need trials about that. In cardiogenic shock, in the SKY classification, for instance, you have the extremis. What is that patient's catabolic nature? How long is it going to last? Should we give nutrition at that point? The second is carbohydrates are the preferred energy source. And the protein prescription is to mitigate the muscle breakdown. And the phase of recovery is when anabolism happens and you go from that to catabolic nature. The RCTs, unfortunately, are all over the place. What you really wanted was this RCT that says, let's give enteral nutrition early on, let's catch up to the enteral nutrition caloric intake, and these patients are going to do great, right? Hypothesis. Patients need more nutrition, I'm going to give nutrition, and the patients are going to get better. So this was one trial where they looked at early, pretty strong, intensive enteral nutrition. It may not project for you all, but unfortunately, when they looked at 40 such patients and compared them to 38 patients that were not getting, look at the bottom. Patients actually did worse. The death rate was 40% in the intensive enteral nutrition group compared to 15.8% with the standard of care. What about parenteral nutrition? Maybe enteral nutrition was bad because of the immune system and the ability to take the gut microbiome, where basically there's translocation happening. Maybe we should just do it IV and things will be better. So early parenteral nutrition, the definition is less than 2 days, 48 hours from the start of critical illness, and late is more than 7 days. The question is whether it was beneficial or not was actually answered in a pretty landmark trial in New England Journal, where they were not looking at 240 and 38 patients, 2,300 patients in each arm. They looked at early versus late parenteral nutrition. Early parenteral nutrition, so you are on top of your nutrition, increase the risk of infection significantly. So one of the guidelines that came out is basically critically ill patients should undergo early initiation of enteral tube feeding, and those patients with insufficient enteral should receive early parenteral nutrition. However, unfortunately, the outcomes were contrary to that. What about, we were talking about MCS, right? What about LVAD patients? This is a big deal. There are many studies that looked at sarcopenia, many as in still few, we need a lot more, as an outcome predictor. And we know that patients with less muscle mass, if you take them for a durable LVAD, they're not going to do as well as patients with good muscle mass. So this paper just came out last month, and they looked at serum albumin, total cholesterol, and lymphocyte count. So the lower the serum albumin, the total cholesterol, and the lymphocyte count as a predictor that your nutritional status was poor. When they looked at the CONUT score, those with a higher CONUT score significantly did worse compared to patients that had a lower CONUT score. Basically, this one showed that is an all-cause death was higher, in terms of ICU stay was higher in these patients that had more malnutrition compared to those patients that did not. So there is no question that nutrition matters in patients with heart failure. Now, to the biggest topic. Unfortunately, heart failure is like a malignancy. It kills. There's no question about it. What kills even more is sepsis. Most often, regardless of you're in a CV ICU, CT ICU, or the MICU, it continues to be the harbinger of death. Here I show you in terms of what is the cost of sepsis, and heart failure is in the second half. But problem is, even whether you look at the National Inpatient Survey or Medicare, you put in one cause of death. So more than likely, sepsis is worse in patients with heart failure, right? What do we know about sepsis and heart failure? We know that heart failure patients are predisposed to sepsis because of multi-organ dysfunction, and septic patients are predisposed to heart failure, right? So it's that vicious cycle. We're trying to understand 24% of patients that did not have heart failure before they became septic and hospitalized actually have heart failure after discharge. I'm going to probably end with this topic in the sepsis, which is Dr. Carr talked about at the last shock symposium. View it as when you intubate a patient, you put it at 100%. Similarly, when you have a septic patient, you start full force and then start de-escalating. You go up from 100%, right? You don't intubate and put them at 30%. You say, I'm going to give everything they got, and then I'm going to come down as they need. Similarly, think of everything you know in sepsis, do it right, do it at that point, and then follow them through. Thank you.
Thank you for the broad overview. Any comments from the panelists or the audience? I'm sure that one of our panelists will have some comments on the impact of mechanical ventilation on the left and right side.
I'm the only pulmonologist here. First, I would say that Dr. Akkanti, you are a silver-tongued angel for bringing up sepsis at the heart failure
Absolutely.
symposium. Thank you. And I agree with you completely in terms of deadliness around the world, deadliness in the United States, and the sequelae of sepsis as well. And actually, I have to say, Danielle, I was so taken by her mention of sepsis that I have forgotten what I was thinking about the mechanical ventilation. But yes, indeed, I think you nailed it fairly well, Dr. Akkanti, in terms of the effect of the mechanical ventilator on the right heart and the left heart. And they are both important, and they both need to be continually assessed.
Thank you.
So what do you think about how to do that? What sort of assessment should people be thinking about? This is for the rest of the panel too. What sort of assessment should people be thinking about when they're looking at cardiac effects of ventilation or alternatively ventilatory effects of cardiac disease?
Well, I think if you have a patient now in advanced cardiogenic shock and intubated, and I think SWAN is important for you to tailor the therapy again. It's going to be about the pressures you are going to get, the cardiac output you are going to get, and to optimize your PEEP, because you are going to have the impact on the things together, and not too early to change the PEEP is going to change to improve everything. It also depends on the oxygenation level of the patient is requiring. And I think there's no, it depends on the data you are going to get from the patient, and data is important. Collect as much data as you can from the patient and to try to put your plan on this patient. And again, data from the vent, data from the SWAN, data from the lab, data from clinical picture of the patient's etiology and all the things, your echo data, because if you might have a shunt, you're also changing the story. Mm-hmm. All that things should be taken in consideration before saying PEEP and which level of PEEP you are going to agree to and what kind of impact do your PEEP have in a cardiac index. If you're measuring the cardiac output and you have the mixed venous sat, you will be every step you are going to do, you're going to have proof for that. Not to be in dark and to say, I'm going to change that and based on only blood pressure or something like that. That would be my approach.
I definitely would echo that. I think the biggest challenge is to, again, these one-size-fits-all concepts. Certainly the effect of PEEP on the RV is substantially more complicated, depending on the degree of underlying lung disease. So if you have a patient with primary pulmonary arterial hypertension, that patient's going to behave very, very differently than a patient who has cor pulmonale due to respiratory failure. And in the patient with cor pulmonale due to respiratory failure, might be an inverted U-shaped curve where not enough PEEP causes their PVR to go up because their alveoli aren't open, but too much PEEP squishes their capillaries, and there's a middle ground. On the other hand, that patient with primary PH, they're just going to most likely disintegrate as soon as you intubate them because they can't handle that extra afterload on their RV. So it's a very different physiology. Certainly knowing that the positive pressure can help the left ventricle is crucial as we think about when to intubate, how to intubate, and when to extubate. We know that one of the biggest causes of weaning failure on the ventilator is heart disease. And so I think that the idea of don't just extubate this patient because their lungs look good, wait till their heart is stabilized. I think that's crucial, and I think that's an area where multidisciplinary care between people with critical care training, people with cardiology training, is crucial.
I want to be provocative and see what anyone else thinks about this. I've been giving a lot of thought lately to the notion of cannulating and CO2 removal to remove respiratory distress, allowing people to breathe with the small tidal volumes they like and not necessarily do the work of breathing, and seeing what effect that might have on both the right and the left ventricle and total cardiac output. I see some heads nodding. Some other people are thinking this too, evidently.
We have, I will add to it, we have the hemolung. We are one of the trial sites for the hemolung, and the thought occurs to us, hey, just put in an IJ dialysis catheter, remove the CO2 and avoid. But I think if you have a patient that has pleural effusions, your VQ mismatch is gone right there at the bottom. It may provide that ventilatory drive, but maybe that in combination with high flow or something that gives you a little bit of PEEP to at least bring the PVR to FRC. Now, that's an amazing combination. It's probably the future in the next 20 years.
Yeah, I'm with you there.
I think that people forget how much of a hemodynamic impact elevated CO2 levels can have. Terrible for the RV, but patients may have systemic vasodilation as well. So I think that the question comes up. I mentioned the primary PH patients. They're the one. They're on the short list of patients that scare me when they get sick. And I've wondered whether they should just go on ECMO before you intubate them. And I think that's the kind of question that I think we should be asking for those kind of niche, super complicated, high-risk patients.
I love to see you guys revisit history a little bit, because Ted Colombo and Luciano Gattinoni thought about that question a lot 30 years ago. And they were the ones that developed ECOR in order to control CO2. So I'm going to throw out to the smart panel here, stop talking about the RV quite so much and start talking more about controlling the pH. Because that's what you do when you normalize the CO2. You normalize the pH, stabilize the cellular milieu, both in the cardiac and the pulmonary circulation. And I'm too old to study that now, but you guys ought to be looking at that.
Done? Thank you so much.
Okay, so you already left. I think we still have a little bit of time to continue the, even though the speaker left. I think that the nutrition aspect is also, I think, a very important one, especially think at the impairment in splanchnic perfusion. Was not so much discussed here. It was much more on the timing and the amount of food, but even when should we initiate the nutrition of our patient, considering stabilization or not of this patient with different devices? Any input from the panel?
So I will say, I just want to put in a shameless plug that my AHA Acute Cardiac Care Committee is actually writing a sort of a scientific statement about that includes some of these types of recommendations. The one thing that a lot of the recent nutrition data has emphasized is that we underfeed our patients. That underfeeding is okay, but not feeding is not okay. My standard joke is, oh, this patient's on the cardiology diet, NPO after midnight. And certainly, that's fine if you're going for cath, but that's not great if you're critically ill. And there's a big difference between just a little bit of feeding and no feeding at all. And I think that as we move forward, I think we're going to find that it's safe to feed patients who are in compensated shock, even if they're still on pressors, even if they're still on circ support, as long as they have adequate markers of perfusion. But certainly, I think that's just, my opinion.
What kind of marker you are using? Give you help on that. Using lactic acid, using what kind?
Yeah, I would say certainly someone who has, normalizing lactate would be on that group. I think someone with a higher rising lactate, not so much.
That's same. We are utilizing lactic acid. Even on inotropes is not a contraindication to start with nutrition, but if lactic acid, this thing going down, that's the time to start with nutrition. Is it okay with that? With any?
Yeah, I mean, I might even go a little further than that. I mean, I think, we, in this room, you talk about when you start trying to think about what the end point in these patients are, and you haven't been feeding them for a month, that's bad. So the idea that you don't feed them in the first 24, 48, 72 hours, and I agree with you fully, a little bit is better than none, but after that acute phase, if you get to a semi-stabilization phase, it's really important to think about adequate nutrition there.
I'd just like to take it a step further, actually, and also add to the complication of when patients are being considered for MCS, durable MCS, or transplant. I mean, we recognize that nutrition's commonly a barrier for their candidacy. So, you reach a point where sometimes that decision is often, compelling to feed the patient in spite of the fact that there could be concerns about some of the complications of feeding, both enterally or parenterally. So I think that also warrants consideration whenever the nutritional aspects are being considered.
In that group of patients, we have to understand also it's going to take time to get the improved nutritional status of this patient. If the patient now is decompensated in ICU and you expect that with you are going to improve him within a short period of time to improve his outcome based on that, I think it's probably too much. It takes time. If you have the patient stable at home and you can, patient with melanoma, you can send him home and give him nutrition for 4 or 6 weeks, that might have some impact. But patient now is required urgent implantation. I don't think that's going to change the outcome of those patients.